Good evening, dear friends. Welcome to today's Critical Care Sunday webinar number 80. And the topic for today is a case discussion based webinar. And presenting this will be Dr. Leelavati Thakur ma'am. Ma'am is the head and coordinator of critical care at Mission Hospital, Durgapur, West Bengal. He has taken some lovely webinars for us before also, especially the last one, which involves two very nice cardiac cases. So this one will be a case, and then there will be some spot diagnosis, a few slides on spot diagnosis, very important pictures. So hopefully this shall be useful to all of you. And on the panel, we have with us again Dr. Jitendra Sharma. Sir's lecture on advanced modes of ventilation has been seen by almost all of you and has gone down very well with you. So Sir is, as you know, head of critical care at Artemis Hospital, Gurgaon, and is also the co-author of a book, textbook of critical care, along with Jatin Mehta sir. And Neeraj Tyagi sir has joined in. Sir is again known to you. He is a consultant at Sir Gangaram Hospital ICU, one of the most prestigious ICUs of our country, at least North India. So without further ado, I shall hand it over to ma'am. Ma'am, over to you.
Thank you, Dr. Tapesh, for a very nice introduction. Good evening, everybody. Dr. Neeraj has joined already.
Yes, yes, he has joined.
I can see him.
Hi, I'm
Hi.
here.
Hi, yes.
Hi, how are you?
Yes. I'm fine, thanks. How are you? Very nice to see you there.
Thank you. Same here.
So we are all old colleagues. So
Yeah, we are colleagues and now we are turning old as well. So.
yes. So Dr. Tapesh, I am not the head right now. I am probably would be a head of unit. My unit is not yet open, so I am acting as a consultant and coordinator. That's
okay,
it. So
it's the
that
same thing, ma'am.
Yeah. So my unit will be open very soon. I think end of August or September. So I'll be there. Now it's my hospital is a multi-speciality mission hospital in Durgapur. So it's a very well-known now, 5th all over India in ranking, if you see. So let me initiate my screen. I'm just. One minute. So is it visible?
No, ma'am, slide is not visible, but you have clicked on something. It's showing Zoom joiner live, Zoom demo.
Achha, okay. 1 minute. Can you see this? No.
Yeah, you can see the screen as joiner live Zoom demo. Now.
Okay. 1 minute. I can see this. 1 minute, just. Where has it gone? Is it visible now?
Yes.
So here I am going to discuss about a case who is very known and very near to me actually. She's in fact a little related to me also. I had actually followed her up from the very beginning when she was at teenage till now. I am following her up. So this is a lady who was fair complexioned housewife. She presented as a second gravida to me, G2P1. This was in 2012. She had an uncomplicated first pregnancy and second pregnancy is complicated. At around 12 weeks, when she met me at Gurgaon, when I was there at Gurgaon at that time, she had a right axillary lymph node enlargement, which was a little tender, but not really troubling her. But she had a resection biopsy of that. That was the biopsy report was inflammatory and not infective. So she did not get any antibiotic for that. And ultimately it subsided. So at 28 weeks, when she was at 28 weeks, in between, she didn't have any problem. At 28 weeks, suddenly she had a swelling of the body, swelling of the lower limbs, and heavy proteinuria. Once she had swelling in the lower limbs, she had gone to see her gynecologist, and 24 hours protein was advised, and it was almost 6 grams in 24 hours with severe anasarca. So obviously she was normotensive. She didn't have any history of PIH earlier. She was euglycemic too. And she was definitely taken up for LSCS by the obstetrician in anticipation of preeclampsia. And then after LSCS, actually it was a preterm boy who had some problem, because there was no time to give betnisol in 2 doses. She only had one dose, and the baby was delivered. So baby had to be on ventilator for some days. Anyway, she was discharged on 4th post-op day. So this was the initial presentation.
So ma'am, I would like to ask you, does this fit in with preeclampsia, that the delivery was made of a preterm baby on the basis of a 6 gram proteinuria without any hypertension
No hypertension. The obstetrician there, they felt that it's
there means where?
May have.
No, there means where? United States or India?
United States.
You were seeing her at that time in United States?
No. She had come to me, and I have thereafter she went to United States, and this was
okay. So you agree with this line of management that 6 grams of proteinuria without any blood pressure change or any other signs of preeclampsia?
Initially I didn't agree to it, but I cannot put my views over there. Actually, I was in Gurgaon. So
okay, so Dr. Jitendra sir, your views, does this fit in with the preeclampsia?
No, not at all. Not at all, because I knew how her teenage was. Just show you.
Let us leave the teenage apart. The case is being presented like this. So Dr. Jitendra sir, you agree that this could be preeclampsia or this is something else?
I think there may be idea about either. They may there not be a confirmed kind of antenatal. They probably didn't believe on the how was the antenatal blood pressures reading. Secondly, maybe because of the systemic disease and causing a problem to the very high level of proteinuria. There may be a thought of I just try to justify their results. I'm not saying whether it is right or wrong.
We have to also look at the fact that the child is 28 weeks of age in the United States. They are more tuned to handling 28 weeks, unlike India. But I think one could have tried and seen why the proteinuria was there with some basic tests and then gone ahead. That is my view.
So going straight forward for delivering of child, I can't really justify it. There could be definitely they could have done a more evaluation, and there's no reason to go for the immediate delivery of the child.
And the other thing is the degree of proteinuria is not in keeping with preeclampsia. Is that right, ma'am? 6 grams is too much for preeclampsia.
Too much. It's too much.
More than nephrotic range. So it's definitely it's not
more than nephrotic range.
Yes, so they should have investigated for nephrotic syndrome here. They should have at least done a cholesterol. The components of nephrotic syndrome are hyperlipidemia, anasarca, and albumin.
Exactly.
5.
So
let's see what turned out to be. But at this stage, there may be so many possibility of so many diseases which can be managed along with the pregnancy. So why to
Okay.
put the additional risk for the premature delivery?
So Dr. Neeraj sir, you have any comments?
I agree that it should be worked up rather than taking a decision on LSCS, but unfortunately, we do not have complete information regarding what led to the decision apart from this heavy proteinuria. But yeah, this should not be a trigger for LSCS per se, any kind of proteinuria, unless it is accompanied by changing in hypertension or any placental signs of insufficiency. Per se, it calls only for workup.
This is nephrotic range proteinuria, as we all agree, and probably this was too premature a delivery, and we should have investigated. But they can be, debated. So let's move on, ma'am.
Yeah. I was of the opinion at that time that why on a sudden proteinuria? She didn't have it till 28 weeks, and the earlier week she had also had. They are very particular about doing a urine routine very frequently, and every week they did it as per the patient.
The thing is, it will not develop overnight. It can develop over
Yeah.
a week or so.
No, sudden. I mean, sudden. It's not the overnight. It's
Yeah.
over a week or so.
Yeah, so that is compatible with nephrotic syndrome if there is a glomerular.
Exactly.
That can happen with acute glomerular diseases, and there are many causes of that. So that is compatible. Nephrotic syndrome may develop over subacute or chronic or acutely.
So now going to the next. Patient was discharged on 4th post-operative day, as I had told you. But from 5th post-op day, she had severe headache, pain in the loin, along with vomiting. And on examination, again, she had a little tachycardia, but heart rate, but the blood pressure was almost normal, 130/84. She had a normal heart and breath sounds, soft, non-distended abdomen, had a healing suture wound, and severely tender both lumbar regions, not allowing ballotment at all. Her GCS was at this point of time was 14/15, and with a mild inconsistency in speech.
So, ma'am,
Post-op
Dr.
day.
Jinder sir, any thoughts on this? What is happening?
So typically for 5th post-op day, a headache and a very subtle sign of the speech and all these things should require a workup for the central venous thrombosis, which is one of the commonest, I won't say commonest, but not uncommon entity. And definitely, unexplained proteinuria in young age group. I don't know what was her previous history over there. Since Dr. Lilavi said she,
Yeah, I'm going to tell
had been
you.
knowing her since the childhood. So maybe any other history of the joints involvements or skin manifestations, or maybe a thrombocytopenia, or all these things. If it is there, then we can extend the diagnostic.
Exactly.
So one possibility is the thrombosis.
At this moment, if you ask me,
Thrombosis.
either it is nothing specific. It varies from nothing specific, just some kind of a post-op little bit bumpy course, to central venous thrombosis, to maybe even any other posterior circulation infarct, and all these things could be possible.
So Dr. Neeraj sir or Dr. Jinder sir, pain in the loin and everything, could it be acute pyelonephritis? And with all this.
So precisely. So if we can combine headache and vomiting, it definitely points more towards a CNS pathology. When it comes to posterior circulation stroke, the only thing which is not fitting in terms of hemodynamics is her blood pressure, which is still normal. She's a bit tachycardic. Pain in the loin is something which, again, we need to put our focus on another kind of differential diagnosis, what is happening in that side, or it could be simply a incidental finding. So first thing would be to rule out central nervous system catastrophe, cortical venous thrombosis, probably any posterior circulation bleed, those kind of things.
Okay, so as the diagnosis coming from both of you is cerebral venous thrombosis, that is one possibility, and vomiting can be explained by that. And pain in the loin can occur because of renal artery thrombosis or renal vein thrombosis. So that gives a unified diagnosis. And patients with pregnancy are prone to thrombosis. Patients with nephrotic syndrome are prone to thrombosis because they lose out clotting factors, which are proteins actually in the urine. And apart from that, the other thing is, it is also possible that there is acute pyelonephritis that can also cause pain in the loin. And if there is, septicemia or what we call sepsis, there can be severe headache and they can be vomiting. So though the severe headache and vomiting are not classic features of septic encephalopathy, but nonetheless, you can have sometimes severe headache and vomiting also, especially if the patient is postpartum. So I think those are the two differential diagnoses. Pain in the loin probably because of cerebral of renal artery thrombosis or renal vein thrombosis. And here we would also expect a drop in the urine output, I think, if there is a bilateral involvement. So I do not know about the urine output drop here.
Yeah,
But you are right, but especially with the young age group and not a really any immunosuppressed state. So afebrile kind of though the fever is not a very specific to the infective origin of the disease, but with this previously non-morbid condition, afebrile gives you some kind of a relook whether I am dealing with the infectious origin disease or non-infectious origin. So that is the first dichotomy we usually do for the any patient who comes for the any problem. We divide into the 4 category. That is our workable kind of way to approach. One, we are very sure we are dealing with the infective etiology possibly. Second is we are very sure we are not dealing with the infective etiology. Third thing is probably infective, non-infective etiology complicated by the infection. And fourth one is can't say. So these are the 4 ways and 4 differentials we always start with whenever we come across any clinical problem. So here I would keep less likely infective, but of course it can happen.
Right.
Yes.
Usually, when we talk about UTIs and anything, even pyelonephritis, once baby has been delivered, uterus shrinks pretty fast, and everything comes off the renal drainage system. So on 5th postoperative day, and a patient who is not febrile presenting with these kind of symptoms is nephrotic, I think Dr. Tapesh, everything is pointing towards widespread thrombosis, and that should be kept the first possibility. Second would be probably any bleed in the brain, if not venous thrombosis. And yeah, way down the line, definitely we need to think of any kind of pyelonephritis, or at times what can happen that you may have a renal stone which can present like this rather than a full-blown nephritis or pyelonephritis, I mean to say.
Right. So carry on, ma'am. I think.
Yes. Next, it unfolds. So thereafter, I had actually dug into her past history, as she had come to me once she was 13 years old. She had a sudden onset erythematous rash all over body. It went off almost for, went on for 3 days and then it passed off. This was a single episode when she was 13 years old. And she had a recurrent wrist joint arthralgia, small joint arthritis in early adulthood when she was around 17, 18 years of age. And she had significant morning stiffness. So when she was 18 years old, she had come to me and I had asked for her markers for collagen vascular disease. It was all negative, from RA to SLE to everything, but it was all negative. Again, at 20, 25 years, she got married. And that time, again, she had this arthralgia, small joint arthritis. She had been extensively investigated for that, but no outcome again. Thereafter, after marriage, she had gone to US. And there, she had gone for some investigation again in US, but again, it came out to be negative. But by the way, there was a suspicion. So she was given a course of steroids at the age of 25 years for a few months, and there were significant reduction of symptoms that continued for long time. So that course of steroids was for 6 months, and it was a tapering last, the doses were tapered off, and at around 26 years, they completed. And thereafter, she never had any symptom further. So no further follow-up. She continued to be all right. No family history of vasculitis related illness that she complained about. So this was the past history.
So what do you make of the erythematous rash? You have seen her at the age of 13, one episode.
Yes.
Is it linked to the arthralgias and arthritis, or is it
At that time, when the rash was there, she didn't have any arthralgia or arthritis. After 6 odd years, she had this arthritis and arthralgia.
So this is probably not linked to it, ma'am, because the
I
common
don't know whether
13 years would be a viral infection. A viral rash
maybe yes.
would be the most common, lasting for 3 days, and no recurrence subsequently at all till we have the present history till 36 years.
Yeah.
My interpretation, the commonest cause of rash, diffuse erythematous rash, is viral infections and drugs. These account for 90% of the
Most of them.
rash.
Yeah.
Apart from that, just for everybody, you can have a rash because of vasculitis, SLE. SLE can have all kinds of rashes. Then you can have thrombocytopenia, which can cause rash. Then you can have scrub typhus. Then you can have some kind of fungal or bacterial infections also can cause rash.
By the way, that rash was never associated with any fever.
Well, that is all right, ma'am. Sometimes fever is very innocuous. You don't get the fever. At 13 years, viral infections are very common. Example,
Yes.
nucleosis itself can cause some kind of a rash, and there are so many infections which can cause a rash, viral infection. 13 years, they are prone to viral illnesses. So my interpretation of this rash would be to ignore it. I don't think this is linked.
Mostly allergic, probably.
Allergy would not go away in 3 days. Allergy is a persistent disease. 3-day allergy rash will not go away unless, because even if it was due to consumption of some food, that food will not go away suddenly. So allergic rash in 3 days, this is a viral rash. I'm pretty sure, because she's 13 years old and this is very common. Some viral illness, but definitely after that, she's having arthralgias and arthritis, and there's morning stiffness. So morning stiffness is highly indicative of inflammatory arthritis, and longer the morning stiffness, greater the chances of rheumatoid arthritis. Classically, the most significant morning stiffness occurs in rheumatoid arthritis, even lasting for 1 hour. But all the other rheumatological conditions can give you morning stiffness like SLE, etc. And then she has, of course, responding to steroids. So as far as the differential diagnosis for the small joint arthritis goes, you have rheumatoid arthritis, you have lupus, then you have the classic polyarthritis nodosa, and then innocuous things like vitamin D deficiency also. Though they will not have morning stiffness, but vitamin D is so common. They get pains and aches everywhere. We should not forget that. And things like fibromyalgias. And another thing very important is gout. Gout does not occur at this age, and does not occur in pre-menopausal women. It's very rare. It is a disease of men. It is actually a disease of the rich, because it's related to rich food, alcohol, etc., but rich men. But it can occur in post-menopausal women. So gout is out. So here, if you look at the arthritis, if it is going to recur, it has gone away. So we don't really know, but it could be a rheumatological disorder. Repeated tests are negative. I presume ANA was done, but ANA, at some point has to be positive if it is SLE.
Exactly so.
But here you see it has regressed and there are no real symptoms. There is mild arthritis. So when the disease is so mild, it can be negative in around 5%. You're not having anything else here. So that is why probably you did not get it. And there are, there's a list of markers now. The list is growing exponentially for investigations. So, the rheumatologists know more about this. We stick to ANA, but there are a lot of tests which can be done to diagnose, this SLE if the ANA is negative, which is in less than 5%. But here, consistent with the disease, because there are no real much symptoms, you see. They had some arthritis and just gone away. So that is the way I would look at it. So Dr. Jitendra and Dr. Neeraj comments I would like to hear.
You are absolutely right. But small small number of SLE patient may not have a what we call seronegative SLE, where the ANA may not be positive. Only this thing is after one episode and there's no further episode gives
No
you a
further
some
rash.
kind of so that's why the autoimmune diseases, if we think of autoimmune disease, they really don't follow the whatever the prescribed rule or whatever the prescribed course is there. Sometimes we find all the other lapses. She was worked up twice, I think,
More than that.
more than that.
Yes.
So, I mean, we need to keep possibility, very high possibility of seronegative rheumatoid arthritis. And it is not too uncommon, particularly in that age, to stay seronegative for quite a long period of time. And probably this is where the short course trial of steroid came into picture before we had all these advanced investigations, which can be done nowadays to prove ANA negative or seronegative rheumatoid arthritis as rheumatoid arthritis. Yeah, so we are looking at that only. But one thing about rash and plus minus fever, a very common infection cause that we need to remember in India, particularly is typhoid fever, particularly in young ages. It does present both in the initial stage as well as convalescent stage as macular erythematous rash. So that thing should also be kept in mind.
Okay, so please carry on.
Yeah. Now, investigations they had done there was almost a little fine, mild anemia. TLC was around 4,500. ESR was fasting ESR was 45, not very much well tallying with the hemoglobin. It should have been around 25 to 30, but it was 45. LFT was normal, KFT again normal, and ABG was okay, not bad. Coagulation profile had shown borderline low platelet. INR was 0.9, APTT was okay. Urine routine had pus cells 7 to 8. Again, a little disturbing. pH was 6 and few RBCs, protein 3+ with granular cast. Stool routine was normal, X-ray chest, nothing abnormality, no abnormality, and USG abdomen had shown swollen kidneys bilateral and an involuting post-op uterus. But MRV was done definitely to rule out the thrombosis part. The abdomen had shown renal and ovarian venous thrombosis, and cerebral, definitely there was a sigmoid sinus thrombosis.
Okay.
So what can
before we come to the ultrasound and MRV, so let us just see the lab reports. So Dr. Jinder sir, your comments on the lab reports, blood reports, and the urine.
Except the ESR is clearly pointing out some kind of you can say vasculitis, connective tissue disorder, or chronic inflammation. So that is the one you can say it is pointing towards that. Rest of the proteinuria that is already confirmed with the nephrotic range of the protein loss, which we have already reported previously. Apart from that, nothing else except this imaging showing renal and the ovarian venous thrombosis and sigmoid sinus thrombosis. When it comes to the etiological cause of it, at this moment, we can think of a hypercoagulable state. One is the pregnancy physiological hypercoagulable state. Second is still we are not sure we can label it as a nephrotic syndrome. Nephrotic syndrome itself is a hypercoagulable state. So at this moment, we can take this finding as a hypercoagulable state secondary to the pregnancy itself or a nephrotic syndrome.
Okay, so Dr. Neeraj sir, your comments? Any comments on the blood reports or the other reports?
So I mean, it's like whenever we look at investigations, we should start what was my pre-test probability. So if I'm thinking of nephrotic syndrome plus minus some rheumatic disorder going back to the history as if we have today, at this point of time, pardon me, we should be looking at anything which tells us signs of inflammation as well as chronic inflammation. So ESR, yeah, 45 is the only thing. I would love to look what kind of leukocytosis or leukopenia this patient is having. Typically, seronegative arthritis, they always have some amount of leukopenia, leukocytosis in them. So I'd love to have the differential here. And I do not know, I mean, if any other test of inflammation in terms of CRP or was done, or if any point of time, if we can, if she was worked up in US, I'll also like to have her anti-CCP levels, what kind of levels they were there, apart from what we have in these investigations. Particularly in this investigation, this urine routine microscopy, apart from proteinuria, is typical of a 4th-5th day of post-LSCS patient. And MRV is obviously clinching the diagnosis for us. But apart from rheumatoid arthritis, apart from hypercoagulous state, combined with nephrotic syndrome, this lady is probably suffering from something else, because the history is now we realize is right from the childhood. So we should keep probing for something else here.
Okay. So just I would like to add here, if you look at the thing, the hemoglobin is a little low, of course, because in the post
Post-LSCS.
state, yeah, so some hemoglobin drop would be there. Then in the LFT, I would be interested in seeing the albumin, and very interestingly, there is no lipid profile even now. So lipid profile is one of the things, because with such heavy proteinuria, one would expect the lipid profile is diagnostic point in nephrotic syndrome. You cannot diagnose nephrotic syndrome. The patient is having such heavy proteinuria, so that would be very important, along with serum albumin. And if you look at the coagulation profile, the INR is actually low. How many times do you see an INR of 0.9? You are seeing an INR of 0.9, and the EPTT is also towards the lower side. So that itself, is a pointer towards a hypercoagulable state. And then coming to the urine, there are some pus cells, there are some RBCs, which generally would indicate a glomerular involvement. If there was a glomerulonephritis, then there would be a lot of pus cells and a lot of RBCs, what is called a nephritic sediment, or what often gives rise to a smoky urine. And protein 3+ is all right. Normally you have to quantify it with the spot urine protein to creatinine ratio, because protein 3+ is a very semi-quantitative kind of a test. And then looking at granular cast. So now what are granular cast? So granular cast, actually, where does a cast come from? Just for everybody, a cast comes from a protein called TAMS, Horsfeld protein, secreted by the renal tubules. This is normal physiology. And when these proteins aggregate with tubular epithelial cells, which are normally shed sometimes, you get a granular cast. And you can get an epithelial cast also. A degenerated epithelial cast is a granular cast. Now, when this TAMS Horsfeld protein combines with RBCs, you get an RBC cast. When it combines with WBC, you get a WBC cast. And whenever there's a degeneration of epithelial RBC or WBC cast, you get a granular cast. So that is, in a nutshell, granular cast. A couple of granular casts by themselves don't have any meaning. Neither do a couple of epithelial cell casts. But RBC casts and WBC casts are always pathologic. And you get hyaline casts in perineal azotemia. And in this thing, in your nephrotic syndrome, you sometimes get lipiduria, which gives rise to waxy casts. So waxy casts is something which you should be looking for here. So, this is from the United States. With due respect to the United States, the workup has to be more precise here. And then we come to the ultrasound. Now you have swollen kidneys. Why are the kidneys swollen? One reason is pregnancy has swollen kidneys. So please remember, one of the causes of enlarged kidneys is pregnancy. We often see enlarged kidneys in acute pyelonephritis, but a differential for that is pregnancy, normally physiologically. Second is, if you give a lot of fluids, the kidneys will become swollen, right? Swollen generally means it's edematous and the size is enlarged. And third, in nephrotic syndrome, because there's anasarca. So here the kidneys are enlarged because of two reasons: is in postpartum state, but more importantly, there's nephrotic syndrome with anasarca. And now coming to renal thrombosis, ovarian venous thrombosis, and sigmoid sinus thrombosis. One possibility is, of course, there's nephrotic syndrome, and like sir said and we discussed, it's a hypercoagulable state. But the second thing here is, does she have APLA, antiphospholipid antibody syndrome, and which would amount to CAPS, catastrophic antiphospholipid antibody syndrome, which is characterized by thrombosis in 3 distinct sites.
So that was one of the thought, but
platelets are
not having
normal.
any history of miscarriages and all this. That is a quite a specific. I'll not say specific, but quite often we get.
But
this
the
kind
kind
of,
of platelet levels are also against,
Sir,
catastrophic APLA.
platelets and all this. See, this is one of the criteria, but that you can have either a bad obstetric history, or you can have you can have thrombosis that has to be supported by your lupus anticoagulant or your ACLA antibody or your beta-2 glycoprotein. One of these 3 have to be positive 4 to 6 weeks apart. Platelets and all can be there, may not be there. So it is a plus minus thing, you have rightly said, but it is not a diagnostic feature. So I'm just raising the point, this could also be APLA, and if it is APLA, it is CAPS. CAPS has, by definition, 3 distinct sites of thrombosis. Just a thought. It may or may not be there because nephrotic syndrome alone can cause thrombosis, but it would be unusual to have widespread thrombosis with nephrotic syndrome.
Okay. All said and done, the people over there, the physicians over there, they were not actually giving in our, demand to see the lupus anticoagulant. So well, I had to literally force them to do the lupus anticoagulant. They were telling that it's only a pregnancy-induced hypercoagulable state. So, but I matched the both. So that is why I asked them, please go in for the markers. So now here it is coming. This was the postoperative protein creatinine. This time she had actually gone into John Hopkins, and now the proper workup was happening here. So these were the protein 24 hours, protein creatinine ratio.
Ma'am, which year is this now? Which year are we talking about? This is how many years ago?
I'm seeing 2012, end of 2012.
Okay.
Okay. So this was this. These are all everything was raised. The creatinine in urine was okay, normal, but urine protein and protein in 24 hours urine was also still high. Specific investigations which was done there was vasculitic profile. Now you see the ANA is more than 1:640. RA was negative, anti-CCP negative, P-ANCA negative, C-ANCA negative, direct Coombs test negative. Complements were pretty low, and anticardiolipin positive. Lupus anticoagulant, that diluted Russell Viper venom test, that was also positive. Beta-2 GP1 positive. So anti-Smith positive. Low C3, C4. This was systemic lupus erythematosus was diagnosed with APLA syndrome.
So we have SLE here and APLA also. So SLE has come out of nowhere actually. I mean, it was one of the differential, and SLE can cause nephrotic syndrome, but there is nothing really to suggest SLE definitively in terms of oral ulcers or malar rash.
No, nothing was there.
Yeah.
The presentation was this only.
Yeah. So, Dr. Neeraj sir, would you like to comment on the investigations, etc.?
Yeah, so they have started the workup of RA, and this is, actually it is very surprising. If you look at the history, I would suspect more of a RA kind of a phenomena rather than vanilla SLE kind of a thing. But she is RA negative, she's as well as anti-CCP negative, as I was saying. We needed to look at anti-CCP, which is negative, and she's ANCA negative, but very strongly ANA positive with hypercomplementemia. So definitely we are looking more at SLE kind of a picture. And again, I was debating just a while back that with not too bad obstructed history, or anytime platelets going down, she does have EPLA. So these investigations are surprising. But yeah, they are clinching the diagnosis.
So, sir,
but this is not a primary EPLA. Technically, it is a secondary EPLA. The primary disease is SLE. So that's why coming to this point is that's why we didn't get a bad obstetric history, because she's not having a primary EPLA. The problem with the catastrophic autoimmune diseases and all these things is they often miss because they are not consistently happen, and when they occur with the episodic way, we have quite oftenly seen in a clinical practice there is something else is going, and the people correlate with this episode with the whatever the disease. Either they were having some infection or trauma or something, some medications, which quite often Dr. Tapesh has already pointed out, like skin rash. Commonest reasons are viral as well as the drugs. So that's why the basic medicine says just to follow what are the common things, but the things are not getting solved, then keep all the rare things behind in your mind. So that's very important, because you just keep on embarking on the same thing again and again. Like we take it as skin rashes as a part of drug reactions only, and we are not able to really fix it up. We are not really able to find out a clear-cut relations with that. Then it requires a full re-evaluation. And what happens here is, what I think she was having a SLE, but it is in the episodic way manner. She might be having a mild kind of in between over there. That's why all our markers in terms of the antibodies, because antibodies depends upon the intense kind of reactions from the body. That's why it didn't happen. And against the usual principle is, whatever autoimmune process gets better with the pregnancy, which is a very, very a basic kind of understanding. Here doesn't hold true. Actually, it is triggered SLE during the pregnancy.
Exactly.
So that's why anything and everything can happen in the medicines. That's what I want to say.
Yeah, we have to keep our minds open. We have to see.
So
the
that is absolutely true, sir. Everything can happen in medicine, but also at the same time, one must remember that when sees a blackbird in the sky, it is more often a crow than a cuckoo. That also has to be remembered.
Exactly.
Common diseases are more common than rare diseases,
Exactly.
rare manifestations. So now just like to point out and comment on the ANA. So first of all, ANA starts from a dilution of 1:40 to 1:80, 1:60, and so on and so forth. This is a very high titer. And at 1:1, at 1:40, you can have at least 10% of the normal population, or some kind of other diseases which can interfere with ANA and give you a false positive. So false positive can be seen in old age, can be seen in drugs, can be seen in HIV, can be seen in malignancies. So there are a lot of false positivity to ANA at low titers. And this is done by the IFA method, which is better than the ELISA. So if you have an option of doing a ANA, please go for IFA rather than ELISA. Then coming to anti-CCP, anti-CCP is more specific than rheumatoid factor for rheumatoid arthritis. But ANCA was not really needed here, because this was not a nephritic segment in the urine. Neither do they cause nephrotic syndrome classically without a nephritic picture, or which I explained earlier. And then complements are arbitrary in the sense that they are more for following the course rather than anything else. And cardiolipin antibody, etc., are positive. Now coming to anti-Smith, anti-Smith is diagnostic of SLE in the setting of ANA. Because see, when you have a rheumatological disorder, it may not be always be clear there are overlaps and there's tissue disorder, etc., etc. And ANA can be positive in all the rheumatological disorders at varying frequencies. But if you get anti-Smith positive, it is diagnostic of lupus. It is only in lupus that you get anti-Smith. The other antibody is anti-dsDNA in moderate to high titers. These two are diagnostic for lupus erythematosus. So that was about the investigations. And the other thing I would just like to add to Dr. Jitender's comments, that these patients often do not come with a clear-cut picture like this lady. The hair also, it is getting complicated by pregnancy. A very common complication is sepsis in these patients. because one, they are having an autoimmune defect. Okay, the immunity is down. Secondly, sometimes they already started on steroids, etc., which predisposes them to infections. So sepsis is often a complicating presentation in these patients, and you have to sort out sepsis from the underlying condition. So that should always be borne in mind. Just adding to what Dr. Jitendra was saying.
One thing one must remember at times in these patients is actually sepsis that was being discussed as one of the possibilities. So you can have a false positive unit to the titer of 1:80 even in sepsis or severe sepsis. The one thing which actually what you have pointed out, that we needed to have entire gamut, including dsDNA and all for this patient. And one other surprising thing is that they despite having 10% of hemoglobin, which is low when it comes to US standard, and evidence of autoimmune disease, they did not go for a Coombs test.
Yeah,
Because
DCT
in pregnancy,
is negative. Direct test.
these are the points which should have been looked at, because when we talk of secondary Epler syndrome,
Dr. Neeraj, DCT
Yeah.
has been done. DCT has been done.
no,
Direct test, yes.
they say direct Coombs test is negative. I understand, because she's a pregnancy, there should be indirect Coombs test as well.
Yeah. So that was
we,
also
we do
negative.
not have the obstetric history, so we should have had the entire gamut of investigations with us. But yeah, I mean, probably they were looking at the patient as well. We do not have multiple you can say peripheral smears on this patient, so we are looking at the point of the slides rather than the entire patient.
Yeah, that's an important point. Just I again wanted to highlight, which Dr. Neeraj again in the beginning already told us, is a pretest probability is most important. Suppose we are having a diagnosis or a clear-cut case of sepsis, and we start doing all the autoimmune profile in the septic patient, probably we may get a bizarre results over there. Probably you may get a 1 or 2 out of the. So here again, what led to going all the further is once we saw the widespread thrombosis, then we are very sure we are having a probability. So that pretest probability was reasonably high when we were ordering these tests in this particular patients. So again, a blanketly ordering the tests, especially these tests in the autoimmune tests in the clear-cut sepsis patient and all these things, may confuse you. Even every pregnancy, if you do these tests, may confuse the person, which will not be able to diagnose properly. So pretest probability is one of the most important points here.
Okay, ma'am, move on, please.
Okay. So her treatment began with low molecular heparin followed by dicumarol at home, and INR was again asked to be kept inside 2.5 to 3. Steroid pulse was given for 3 days, followed by oral steroids, started on azathioprine. Definitely these all treatment had actually gave rise to, improved the condition of her. Azathioprine and HCQS started at that point of time. She was discharged home and asked not to breastfeed the baby. The baby was by then after 10 days on being ventilation, baby was out from ventilator, and he was not allowed to get the breast milk of her, and she was advised for kidney biopsy, but obviously she was on dicumarol, high dose dicumarol or low molecular heparin. We couldn't do a kidney biopsy that time. So it was posted a little ahead. So after 2 or 3 months, she had this kidney biopsy. So this was the kidney biopsy report. This was class 5, membranous lupus. Lupus nephritis. So this was done after around 3 months of her initial, the pregnancy and the LSCS. After 3 months, after stopping the anticoagulation for a while, she had this. There were focal vacuolations and some microvillus transformations like spikes. These were there. So let me be a little more clear about the classification of lupus nephritis. You can see that class 1 is minimal mesangial, 2 is mesangial proliferating, 3 is focal lupus nephritis, diffuse lupus nephritis, and it was class 5, membranous lupus nephritis, almost going towards class 6. So prior to getting the advanced sclerosis, the sclerosis already has begun in membranous lupus. You see, the thing is so much, I mean, was kept under, I mean, she had such a progress disease, but without any much of symptom for 10 years, because she had a course of steroids. I do not know that had suppressed her symptoms or not, but this was there. So this was there in kidney biopsy.
Okay, ma'am, carry on.
Yeah. Then she was started on mycophenolate mofetil. Had to be stopped. Imuran means azathioprine for after a few days because LFT was getting deranged. She had proteinuria almost controlled within next few months. And I'll just show you some further course till from 2015 to 2022. She had bouts of cough and breathlessness off and on, started on bronchodilators, advised for X-ray chest and CT thorax. Lung function test had a mild restrictive lung disease. And she, in the meantime, she had a very variable INR, and dicumarol had to be very much well adjusted and changed according to the INR. Frequent flares she had at different times. So now see the lung radiography. Here she had to be reintroduced on azathioprine and short course of oral prednisone when she had this cough and bouts of breathlessness.
So, ma'am, if you go back to the X-ray, so
Yeah.
everybody, this is
It looks like she's having a maybe a ILD kind of a
Yeah. Yeah.
X-ray.
ground glassings, peripheral ground glassings are there.
And the X-ray is showing reticulonodular shadows more at the bases. The diaphragm is hazy, and the cardiac solute is also getting a little hazy. And the film is probably, I don't know, cannot say whether it's expiratory film or the lung volume is reduced. Unlikely the lung volume is reduced because the defect is very mild on spirometry. So this is probably a expiratory film. But definitely the bases are hazy with reticulonodular shadowing, and CT, like Dr. Jitendra said, is having peripheral ground glassing. So, and of course, there will be much more to the CT. We are not the experts on CT ILD, but this is what can be made out on lung radiography.
Now some trends she had. I'll show you the trend of ESR over the time. From 2015, these are all I got from her Johns Hopkins site. She has got a site there. So I got it from Johns Hopkins. So this was the sedimentation rate, like very, very variable between. So you can see that from here itself that she had so many flares. So the lowest was 10 or 12 at times, but mostly above that. You can see that. And now about the proteinuria over the time, even you can see that in last year, she had some high protein creatinine ratio here. Last to last year also from 2021, like that. And in October 21, she had another kidney biopsy. Again, that class 5 membranous nephritis. Then again, she had to be initially, we had to increase the mycophenolate dosage. again it had come down. You see, this was latest in May 22, and see the protein creatine ratio has come down. So level of protein in 24 hours. These are all trends that I got from there.
Yeah, I was about to ask you this. I mean, trend of compliments.
Yeah. So you can see that. C3 is this one. This was pretty low initially, then had touched up, then some moderately low kind she's maintaining. And this one, again, C4, this is the same. Here the control is this line. Here also the control is this line. And this one, you can see there are topsy-turviness. So it's still going on. She's still going on. And she had many flares in between. Once I had to go to support them to US.
Okay.
The anti-cardiolipin antibody trend, it had come down over the time. Here you can see the second, this thing, it was cardiolipin IgG. This was IgA and this is IgG. IgG had come down, again it's going up. This is not a good sign again. And now Russell Viper, diluted Russell Viper venom time. This is actually lupus anticoagulant. This is still above the level, still above the level. APTT.
Actually,
Yes.
very interesting thing is that when you do the, when you have this thing, the prothrombin time is actually, is actually increased, the APTT with lupus anticoagulant, but that is in vitro, but in vivo it actually causes clotting.
Yeah.
Coagulant.
So this was it. Again, the dosages were revisited. The second kidney biopsy, you can see the report. I have directly posted this kidney biopsy report from there itself. So it was again segmental membranous deposits there, and mild arteriosclerosis has added on as she has aged a bit. She is now 46 years old. So increased MMF dose further. Now present condition, now she is a 46-year-old lady, a high school teacher there in Maryland, very near to John Hopkins. They have chosen their, home there. And she is a performing artist as well. And she continues to be on Imuran, means azathioprine, mycophenolate mofetin, coumadin derivative still going on. Often on steroids she needs because she had repeated flares, developed bony pain and visible swelling on mid-dorsum right foot a month back. This is a new development in her. Tender swelling on second metatarsal.
How is she going to perform if she is having problems with the foot?
No, she is a performing artist, means she is
dancing. She's a singer.
Yeah, she does other things actually. It's not. So she has a tender swelling on second metatarsal head region, right foot. Now, what can this be?
So I feel this is actually, so Dr. Neeraj sir, you'd like to say anything?
Before we reach here, I think we should tell audience how to monitor SLP. That's the most important part, and how we upgrade or titrate the therapy. So to me, again, I'm really surprised. Usually the dictum is we follow 3 or 4 trends. One of them would be definitely proteinuria and PC ratio. Second is the ANA titers. In somebody who had ANA titers of more than 160, and she had stage 4 SLE. The best way to look at her would have been the trends of complements, ANA titers, and then you combine it with proteinuria and those pictures. The second surprising thing with this patient is like the way they, I don't know what the kind of steroid dosages they were giving. That part is also missing, and then they kept going back and forth with azathioprine as well as MMF. Dr. Tapesh.
Yes.
Dr. Tapesh, I mean, this is something we should be telling the viewers first, and then we can come to these complications as well. Yeah.
Yes, yes, that complication is not so important. Is probably she developed necrosis of the foot, osteonecrosis. Osteonecrosis can occur in these autoimmune conditions.
So precisely, I mean, if
technically, she was never in the remission.
yeah.
Again, my concern is there is always some kind of a flare up, and she never show a complete remission over there. Is there any role of biologics at anywhere in that state where
Exactly.
she
So
never went
rather-
under remission kind of this thing? Eventually, we land up because she's in the young age, so that we may not be able to appreciate the complication. They may not surface till they reach to a certain level over there.
So, in the biologics as of today in SLE there are two situations. One is actually use it in mild to moderate disease, which is not like life-threatening here, which is refractory to standard treatment with HCQS or your NSAIDs or your steroids. Mild to moderate disease which require aggressive therapy. So that is one situation where you use biologicals in SLE.
So will you label it as a refractory or still remission? Because whatever the trend we have seen in this patient.
No,
Just-
I think this is all right. She has responded to treatment. They behave like this only. You are not able to control entirely. SLE is a disease of remissions and relapses mostly. So there have been periods where she's able to go to work. She's doing well. You cannot control the disease entirely in all the patients.
Okay.
And if it is very severe, then there are certain biologicals which have come up, which are used only after initially using steroids, accompanied by either cyclophosphamide or mycophenolate or azathioprine. You have to use your experience. This is the purview of rheumatologist and what they want to use. And
this is what I'm exactly not able to understand, that she was the dose of steroid, if at all, and why it was stopped. Because earlier there was no such sign like there is any osteoporosis or any such thing which are present now. The only issue was derangement of LFTs, which I don't think steroid cause that kind of side effects ever. So that's one piece of information why the steroids are missing on her. That's one thing I'm not able to understand.
Actually, she is often on steroids. She is often on steroids because whenever she is having flares, she is given a steroid, a course, and then again tapered it off. She comes back to normal Imuran, MMF, and Coumadin, and again at times she is having flare, but she is not continuously on steroids. That's for sure.
so that is actually steroids are definitely used initially in the induction phase when you want remission, and then for a few months after that. Subsequently, there are different situations and different experiences and different schools of thoughts, and you have to use immunosuppressants depending on the situation, and you have to fine tune it. So that is about it. And she was given steroids initially. You have rightly pointed out she's not on steroids now, but this is a very long history now. So you cannot.
Yes, it's a long history.
Steroids, and you have these drugs are better than steroids. Steroids have a lot of side effects, as you know, over a long period. And she's a young lady, so steroids can't be given for such a long period.
Actually, she needs steroids at times because she experiences flares. I mean, at least 2 to 3 times a year. It's so frequently.
So okay. So I think now we should just conclude this from my side, and then if Dr. Neeraj or Dr. Jinder want to say anything. So this was SLE with a somewhat unusual presentation, in the sense she presented with nephrotic syndrome, which was never diagnosed properly because you need a lipid profile to diagnose nephrotic syndrome.
I believe that lipid profile was done there from John Hopkins, but it was almost, I mean, in the normal range. That was
right. So
never.
we can't, unless you have a hypercholesterolemia, you cannot classify nephrotic syndrome strictly, and you have to look at the serum albumin. You can just say this is a nephrotic range proteinuria because the duration of the disease was not so much. Probably that's why she never developed nephrotic syndrome. And there was just nephrotic proteinuria over a couple of weeks, and that was controlled immediately with delivery. We had nephrotic range proteinuria, and as far as nephrotic range proteinuria is concerned, it can be seen most commonly with primary glomerular diseases. Then that's a broad group of diseases. We won't go into the particular subtypes. She has shown you some of the subtypes. There are many subtypes, as you may remember from pathology. Then the second group is SLE and other autoimmune conditions. Then there is cancer. Cancer can also cause, common amongst them is lymphoma. Then drugs, common amongst them is NSAIDs, chronic use of NSAIDs. and then infections, Hep B and Hep C. Hep B and Hep C with cirrhosis can have nephrotic syndrome kind of a picture or nephrotic proteinuria at times. So that was about nephrotic syndrome. And then she had secondary APLA, as we discussed, and catastrophic APLA, you can call it at that.
Yes, it was a CAPS.
Yeah, CAPS has to be treated with IVIG classically. You have to give intravenous immunoglobulin or even rituximab at times. It is quite serious condition. Sometimes it can lead to severe organ failure. So there were too many things happening there. There was pregnancy also. There was nephrotic proteinuria leading to some kind of coagulopathy. So you can't really say how much of it was being contributed by APLA, you know, because
It was all combined together.
yeah, so maybe that's why she didn't do too badly. Otherwise, it can be very severe. Multi-organ failure and death can occur if you don't use IVIG.
Exactly so. Exactly so.
Yeah, and lastly, about the lupus involving the lungs. So one was ILD, which is a classic presentation. Then the other is pleural effusions, which is probably the commonest. Bilateral pleural effusions, which are exudative.
Very, very common. Yes.
And a very serious condition is, which all of us have seen, is diffuse alveolar hemorrhage, which we deal every time. And another one, which is not so rare, but which not so common, but is there and very difficult to distinguish from pneumonia, is lupus pneumonitis. Lupus pneumonitis is just like a pneumonia, bilateral infiltrate, short history, hypoxia, goes onto the ventilator, and it's very difficult to distinguish.
Yeah, exactly so.
And there you have to
Now we are having that one patient of lupus pneumonitis. Yeah.
Okay, great.
Right now we are having that patient.
So it's great that you have been able to pick it up.
Yeah. So again, you see, she had a bony pain and swelling on the second metatarsal head region. So what it can be? Most common that occurs is this. You can see that. The impression, you can come down straight to the impression that right second to metatarsal phalangeal joint abnormality, suspicious for sequelae of second metatarsal head AVN. So she has now a AVN in the second metatarsal head.
So these are all complications of autoimmune disorders and drug therapy, etc. So I think let's move on, ma'am, now to the second part. Dr. Jitendra sir, you want to say anything before we conclude this and go on to the
No, we can continue. Or
okay.
Now, coming to the second part, these are very interesting patient presentation. You can see that this is a 24-year-old lady who had severely restricted small joint mobility in the morning. What is there in the radiology?
So request the audience, if you want to participate, you can type the answers.
Yeah. And which investigation we are going to do next in this lady?
So anybody wants to write? So we'll be showing them spots. So if anybody is comfortable and wanting to write, please write. Okay, ma'am, I will think that rheumatoid arthritis. She's a 24-year-old lady and restricted small joint mobility in the morning. Commonest diagnosis will be rheumatoid arthritis. And I would like to do anti-CCP. One investigation.
Yeah, this is what is needed now. Anti-CCP is the answer actually. And here you see, most of the time we just do not see the radiology of a new onset small joint mobility restriction for a patient. We wait for the deformity to occur probably to diagnose a rheumatoid small joint involvement. But X-ray is very helpful for us. You can see these erosions. You can see these erosions are very, very, very prominent here. These are the small joint erosions. So going on to the next one.
So I would just like to say that anti-CCP is better than anti-rheumatoid factor for the simple reason that anti-CCP is very specific. If it is positive, it means it is rheumatoid, while RA factor can be positive in many conditions. So the sensitivity of both is same. But one investigation most cost effective for rheumatoid arthritis is anti-CCP and not rheumatoid factor.
Yes. And along with that, we should ask the patient to have a X-ray hand also.
X-ray hands helps, ma'am, but the thing is, a lot of arthritis kind of look same and is difficult to, even
That
SL.
is it. But
Yeah.
so I mean, if we see this kind of a hand X-ray, we should think about it that we have to do a RA and anti-CCP.
Yeah, you mean it is more,
Yeah.
evidence-based that there is something happening rather than diffuse myalgias and all.
Yeah.
Okay.
Okay, coming to the next one. This is a telltale sign. Which kind of sign is this? This is a middle-aged lady having numb fingers, both the hands, sudden discoloration of the ring finger followed by severe pain. She also has proteinuria and renal failure.
So we'll wait if anybody wants to answer, but I think they are all very difficult situations for our intensivists. But
So I
This
think
one they should.
This sign is very
Yeah.
well to everyone.
This one they should.
so I think I'll answer that. This one is actually Raynaud's phenomena.
Yes.
Raynaud's phenomena has three phases. One is pallor, then there is cyanosis, then there is erythema. And because of the intense ischemia, you get the pain, and proteinuria, renal failure are part of scleroderma. So I think this would be scleroderma, and the picture
Exactly.
is classically scleroderma. And numbness, fingers, both hands, is actually maybe because of so many reasons. Probably she has carpal tunnel syndrome or something in the hands. So that is another feature in scleroderma. But leaving that aside, right now what is being shown, if the man can correct me, is ischemia. So pallor, and then cyanosis, and then you get erythema. So this is Raynaud's phenomena, which is diagnostic in two conditions. One is scleroderma. Scleroderma, the earliest changes are you get skin changes on the hands of fibrosis, tightening, and then Raynaud's phenomena. So Raynaud's phenomena can occur with scleroderma. It can occur with Sjogren's syndrome. These are the two common autoimmune conditions, and of course, rarely with the other autoimmune. And then there is a primary Raynaud's. So primary Raynaud's is seen in 5% of the population. It is associated with just exposure to cold and some cyanosis and pallor in the hands, and it is a benign condition. So that was a little bit about your Raynaud's phenomenon. Am I right, ma'am? This is Raynaud's phenomenon.
Yes, absolutely so. Absolutely so. You are correct.
So carry on, ma'am.
Should I go to the next?
Anytime you want to add anything, please go ahead.
Yeah, okay. So it's 34-year-old gentleman, history of nasal congestion, hemoptysis, knee joint swelling, and pain and renal failure. Actually, these pictures are not the actual pictures, so I have taken it from net. This patient, he had presented to us with a sudden onset hemoptysis. So hemoptysis, he was admitted under a chest physician who had asked for a CT chest. You can see the CT chest was like this, and he asked for a bronchoscopy for this. And we had gone through the entire history of that patient. I had seen that that patient has gone to the orthopedic surgeon also, who had asked for a knee replacement for him. And he had shown it to some ENT surgeon as well because of nasal congestion. So
I can give a spoiler here. This is how catastrophic autoimmune renal failure presents mostly in ICU. So,
this is a classic ICU setting, actually. This one.
Very common, very
classic
common.
ICU setting.
Both the CT especially is very classic in the ICU with hemoptysis. This is a pulmonary renal syndrome. So friends, you should be able to pick this up. This is a pulmonary renal syndrome with nodules on CT and is cavitating, cavitary nodules.
Yes, cavitary nodules.
So pulmonary renal syndrome with cavitary nodules, and there is a nose deformity, if you can see. So that
Yes.
you may not know, that is a saddle nose deformity. So this is Wegener's granulomatosis, classic.
Classic of
Nose is showing saddle, is called a saddle nose deformity due to the associated sinusitis and associated destruction of the nasal cartilage and the bones. And this nodule here is most interesting. Is called, they can be cavitating or non-cavitating. So there are very limited differential for cavitary nodules on the CT, which is a very common finding in the ICU. So this should be on your fingertips. One is venous granulomatosis, then most commonly, I'm going in a haphazard fashion, tuberculomas, then fungal lesions, nogardiosis, metastasis, which would probably be the first, along with tuberculosis and venous. And third would be your, very important again is your septic emboli. They are peripheral in distribution and they cavitate. That is another very common scenario. So if you get this kind of a picture, bilateral, here is unilateral, there's a small nodule on the left side. But if you get bilateral nodules, cavitating or non-cavitating, more actually towards cavitating, then these are the 5-6 differentials. So please remember this pinches the diagnosis actually. And here, this is a classic venous granulomatosis. And another thing I would like to add for venous is that people often do plasmapheresis for the renal failure. But recent trials and meta-analysis have been published which show that these patients do not benefit over long term with plasmapheresis. The outcome is not improved. So plasmapheresis is probably not to be done in these patients if they go into renal failure. You have to manage with immunosuppressants.
This patient was given rituximab finally.
Yes. Yes.
So very, very important. Iota of suspicion has to be there whenever a patient presents with a hemoptysis. We have to look for other systems as well. That is the learning point. Next, this deformity is very common, very commonly seen in which kind of collagen vascular
Okay,
disorder?
so if I'm not wrong, this should easily be rheumatoid arthritis.
Yes.
This is a swan neck deformity in the little finger. If you see this is forming a swan neck, so this
Yes.
is classic swan neck deformity. The other deformity is the reverse of swan neck, which is called the Bordenier, and sometimes there was Z-shaped deformity. These are the three kind of deformities classically described in rheumatoid. And then the lungs is showing interstitial lung disease. There's ground glassing and whatever the
Typical of rheumatoid lung. Yes.
So you get the classic Velcro crepes in this, huh? Just auscultation will give.
Velcro crepes. Yes. That is the learning point here. So they should know about how the Velcro crepes. I mean, we can hear the quality of the crepes will be very granular kind of a crepes.
So friends, we are going through this just to give you the basic highlights of these diseases, to give you a broader outlook towards the patient. When you see all this, these are spot diagnoses, you don't have to think too much and you know what the patient is having. Because patients sometimes come like these only, they don't have rheumatoid arthritis carrying papers and written over them in any ink or anything like that. But they have rheumatoid arthritis written over them in their joints, in their facial features, over the signs that they have. So if you get this, you know what you're dealing with and half your job is done. But the diagnosis is the most difficult part. Treatment is easy.
So for this, the PFT, patient having sinusitis, polyarthritis, epistaxis, and lung changes, definitely there. And the respiratory, the PFT graph is like that. It's a skewed kind of a graph with low FVC and low TLC. You can see, keeping the FEV1 FVC normal. So what is the change in the PFT? What kind of a lung disease is this? This is a restrictive kind of a lung disease.
The lung volumes are reduced, ma'am, and there is
total lung capacity is
Yeah.
reduced and if FVC is reduced.
okay.
But FEV1 and FVC ratio is not altered. So this is a restrictive kind.
So if I cannot show this, but there's no scooping also on the expiratory flow and the lung volumes are reduced. So that can
You can see a little, I mean, skewed kind of.
Then there's the obstructive component also here. This is the expiratory flow. Then there's
Small, yeah.
similar scooping,
Small
but there is no scooping here. You see in this one. Sometimes it's very difficult to say. You have to repeat it again. This is the lower one is normal.
Lower one is normal.
Only inspiratory phase here. Because
Only inspiratory phase, yeah. So going to the next one. 40 years lady having fever, rash, myalgia. These were the signs, very common telltale signs of a significantly very, not very uncommon kind of vasculitic disease. What are the signs? Yeah. This one is
Actually, this is
rash.
a difficult one, but myalgia, fever, rash, unless if there's a myopathy, myalgia is very non-specific. If there's a myopathy, muscle weakness and all, then
Yes, muscle weakness, myalgia and muscle weakness as well.
yeah, so then it could be dermatomyositis, because
Yes.
it's kind of a rash. I cannot say about the finger, but the rash is definitely can be seen in because you're dealing with rheumatology conditions. This should be myositis, dermatomyositis.
So vena callitrop rash, these are all Grotton's papules. You can see Grotton's papules, Grotton's sign here. And there is diffuse calcification of the soft tissue. These are all signs.
But usually, I mean, they do have some kind of girdle weaknesses as well alongside.
Yes.
So yeah, this is difficult.
Yeah, this is difficult.
So what is happening in the X-ray? There's some calcification.
Yeah. Dystrophic calcification here. You can see that these soft tissues are getting calcified.
This is the most important thing about dermatomyositis. They are a syndrome, and if you have a dermatomyositis, it is very important in women to rule out certain ovarian and all those reproductive organ malignancies.
Cancers, okay.
Exactly.
This is very important.
Yes.
If they are presenting in a non-classical way to see if it is a secondary dermatomyositis rather than a primary dermatomyositis. This could be a part of a syndrome.
Yes. So going on to the next one. This was not the exact picture of my patient because I forgot to take the pictures. This was a 45-year-old lady being treated so far as AKI on CKD, significant proteinuria, hypothyroidism detected from somewhere else. The incidental finding was tightening of digital skin, ischemic acral ulcers. You can see this. These were there. And this was the tightening of the oral cavity, this thing.
So ma'am, this is very easy. This is scleroderma is written all over it. This face with the, the puckering of the skin, the pain,
Yeah.
nose, the fibrosis on the cheeks. So this is classic of scleroderma. And you have this thing, calcinous is cutis here. And I think that's about, this is easily scleroderma.
Yeah, she was being treated as hypothyroid lady earlier by some endocrinologist. You see, we become sometimes so tubular in vision, we do not find something else for this hypothyroidism, which was actually in turn, and hypothyroidism and AKI on CKD she had. So coming in terms of both the things, we had sent her for specific investigations. Mostly you can see everything starting from ANA, anti-dsDNA, Pianka, Cianca, and the things also, anti-SCL70. Specifically for this lady, we had sent that anti-SCL70, which became positive.
Okay, ma'am, next slide, please.
Yeah. This was one of my neighbor who had
You get a lot of family, friends, and relatives.
Now, that's what I'm saying. You have autoimmune people all around you.
Around. No,
All around you,
those
huh?
were my patients, but this was my neighbor. And the main presentation was my relative. So this is a 35-year-old male who had repeated eye irritation, used to swallow food with help of water, and itchy dry skin with rashes.
Ma'am, this is dry eyes and dry mouth. So this is
Sjogren syndrome.
yeah, Sjogren syndrome.
This was keratoconjunctivitis sicca.
Keratoconjunctivitis. Yeah.
Now, this is the last one. 40-year-old lady diagnosed rheumatoid patient is on biologicals already, having severe mobility restriction in the joints, particularly the left hip joint and right wrist. The X-ray finding.
And she's having
Actually,
AVN.
ma'am, this X-ray is not our purview, so I don't think.
No, but we have
Yeah.
to, I mean, keep it in mind that we have to look at it also.
Yeah, but being on biologicals, if the history is compatible, one would like to think of some kind of a fungal infection or something, but I don't know.
This is, no, this is avascular necrosis.
This is AVN. This is AVN. I mean, and this is, I agree with the Dr. Leelavati, because at times these patients, they come to us and the AVN gets diagnosed while they are in ICU, and one should be aware on all these patients who are on long-term steroids that they could be having asymptomatic one, and all of a sudden one day we find it and we disclose it to the family. So this should be part of initial work of any severely ill patient who has been on long-term steroids, to look at all these areas which are prone to AVN.
Yeah.
So you have experience with AVN?
Yes,
Sir.
yes, I'm saying we had a bad experience.
So
We had a
what
bad
are
experience. Patient was with us, and when we weaned off the patient, we are about to rehabilitate the patient. And when we started to make her sit, she was tossing all over. She had bilateral femoral neck avascular
oh
necrosis.
my God.
Oh my God.
She was a 68-year-old female who was, I still remember the bed number. Leelavati, she was on bed number 27, that corner bed, counter,
I can remember.
counter 4. Yeah. And we were at our wits' ends to explain to the family that this did not happen during this admission.
Yes.
Because she was in ICU for good 4
Absolutely.
weeks.
Yeah.
It
So this happened after getting well, so towards discharge.
So no, she was in ICU.
She was in ICU.
She was a very difficult patient who had repeated secondary sepsis. She came to us with community acquired pneumonia. She was on steroids. She was a rheumatoid arthritis patient. And when we took, she was weaned off, and during rehabilitation was when you start to make them sit and you make them sit with their legs hanging down. That's when we picked up the problem. And unfortunately, we had nothing done before that in terms of her pelvic X-rays and all. And the
Exactly.
first pelvic X-ray showed bilateral AVN.
Again. So this AVN is a great problem in majority of these kind
That's
of
a big
patients.
issue.
Yeah, this is a big. So we should be, I mean, keep our eyes and these things open, clinical suspicion open, to see whether they are having this kind of avascular necrosis or not. So I think, no, this was a last one. This was again one of our patient who was in Max, the Saket City Hospital, that was Max Smart Hospital. So this was a 30-year-old lady, diagnosed case of lupus nephritis. She was getting treated by one of our nephrologists and presented to ER with intractable headache and GTCS, repeated GTCS, and vision loss in both the eyes. She
This is
regained.
for Dr. Jitendra. Dr. Jitendra, sir, you are the specialist in CT and MRI brain.
Yeah, showing some kind
This
of
one is a CT. This one is CT and the MRI pics. This one pre-treatment, and this is post-treatment.
and MRI is T2 actually. It's showing a T2 sequence of MRI. It's showing a lesion in the bilateral occipital lobe. So maybe a cerebritis secondary to the lupus nephritis. That is one of the possibilities.
I've seen at times even venous thrombosis presenting like occipital infarcts. So I'll love to have a MRB on her as well.
Okay. So it was actually a press.
Okay.
Yeah.
Oh, yeah, it could be. Man, but you should have given us a blood pressure as well then.
Yes,
Ma'am,
I
you
didn't
have
agree.
you have not given enough
Encephalitis.
information.
I'll think,
that was
I'll think
yeah, that was
catastrophic
missing
cholera and
here.
all. You know, we are thinking
Hypertension.
more like MCQs than clinicians now.
It was
Information would fail everybody. That kind of
Information.
Yeah.
information. Actually, this patient had specifically to show this, she had repeated GTCS. She definitely had 220 over 140 kind of a blood pressure on presentation.
Then I'm taking press.
Yes, and it was not getting all right at all unless we had given her pulse steroid and cyclophosphamide in spite of her being greatly hypertensive in hypertensive emergency. Obviously, she was getting all antihypertensives and she was on ventilator because repeated GTCS, she was in almost status epilepticus. So we had to put her in ventilator. But significantly, this vision loss was improved within next 5 to 7 days. Once the pulse steroid and cyclophosphamide were given, she improved a lot.
So the cause was accelerated hypertension in nephritis.
Yes, yes. Accelerated hypertension in nephritis.
Okay. So a lot of rheumatology. I hope it was that is the last one, or there's some more.
This is last one.
Okay.
I'm not going to bother much. This is the last one.
So the information was very scanty. I think we have done well overall. We must
It was great. Entire gamut of presentations. It was really a huge effort from your side.
Yes.
Almost all the catastrophic autoimmune presentations in ICU. It's a really commendable job.
Yeah, really, those to show
Definitely.
diagnosis of the rheumatological conditions is a good teaching point and slide for all the students, because these are clinchers. You see this, you can clinch the diagnosis actually. So
Yeah, that's fine.
sir, anything finally you want to say before we go to Dr. Jitendra sir?
No, I think we said enough for ourselves as well as for the students, and especially I really congratulate Dr. Lilavati for such a nice collection, and all are relevant to the ICU, and even whatever we have discussed for all these rheumatological illnesses pertaining to our session. These are relatively having a less learning curve. So mind actually, what I see, mind knows these are the things only. So once the our student or our intensivist colleague, once they see the avascular necrosis X-ray or sometime the dislocated shoulder X-ray, so because we do X-ray quite often in ICU with a different intent. We do the chest X-ray just to see the lung field as well as the devices and all these things, but we forget to see the dislocated shoulder joint, which later on create a problem, because once the ICU stay is prolonged, you miss, and all the X-ray and imaging actually they created the history. So if we diagnose later part in the course, then everything blame upon what we are not diagnosed previously when the patient underwent a such and such imaging. So this is also important. What is obvious? So intensivist should pay attention. What is our lacking, or I would say good intensivist should be one is our core part of the training, which is a core intensive care. Simultaneously, they should have some basic knowledge and some few things which is clearly one can recognize it. Then it makes a good intensivist over there. Probably rheumatology consists a very last part of our intensive care training, but I learned a lot from the Dr. Lilavati today. And
No. I have learned also from all of you.
We are all students, and teachers always learn when they try to teach more than the students sometimes. So the only thing is, ma'am, you have rightly chosen a bright topic for learning, because this is an unexposed area for all the intensivists, and you have picked up the right kind of slides, because these are diagnostic pictures. So
Yes.
the important thing is, when the patient comes to you with a complication to the ICU, these patients always come. Rheumatology patients
Yes.
are coming. If you don't have a rheumatologist in some centers, then they may not come. But any proper hospital will have a ICU where rheumatology is being practiced, and they will come. The idea here is the test for rheumatology don't come back immediately. So you have to make a clinical diagnosis, working diagnosis.
Exactly so.
ANCA, Shanka, everything comes up back after 4 or 5 days.
Yes, absolutely so.
Diagnosis is very important here. When you have diffuse alveolar hemorrhage going on there, and the patient is pouring out blood and everything and not being getting related, you have to have a differential diagnosis, in the clinical differential diagnosis.
First of all, you have to have a suspicion. You have to have a suspicion for.
Yes, working clinical diagnosis.
The
Yes.
funny thing is, in our ICU, most of these patients, they don't come to rheumatologists at all. We have a great rheumatology department, but almost all of them, they come for nephrology related issues.
Yes.
And it's either the nephrologist or the intensivists who are making the diagnosis nowadays, because there is so much of exposure. And this is what probably is the take home message, that any sort of AKI, when we talk in today's time, particularly in young females, and probably then the second peak is after 60s, one must consider autoimmune diseases in presentation and look for these non-infectious causes. I mean, our ICUs, particularly tertiary care ICUs in metropolitans, they present more of a Western, demographies now, rather than Asian
Exactly.
demographics. So these non-infectious causes are becoming really important. And the other good thing about them is, as Dr. Jitendra pointed out, the outcome and prognosis of these diseases is much better as compared to infectious ones. If you have, as Dr. Tapas rightly said right now, if you can pick up and you can have a differential diagnosis or a working diagnosis, probably will at least give a pulse steroid therapy, which will halt the disease. And then you can take it from there by the time your immunological markers, they come back.
Exactly. So.
Absolutely. So I think, is that all, sir? Then shall we close the session, ma'am?
Yes, enough information for a day.
Yeah. Okay, so thanks everybody. Thank you, Dr. Leelavati ma'am,
Thanks.
Neeraj sir and Jitendra sir, and thank the audience for the patient hearing. I hope you were able to contribute to this rheumatology teaching. Thank you very much.
Thanks. Take care. Bye-bye. Have a nice Sunday. Bye-bye.
Bye.